Welcome, everyone. Thank you for joining us. We'll let folks get settled in and we will be starting momentarily. All right, again, and welcome and thank you so much for joining us for this webinar on buprenorphine initiation in the age of fentanyl with our presenter, Elizabeth Salisbury Afshar. Today's presentation is brought to you by the Great Lakes ATTC and SAMHSA. The Great Lakes ATTC, MHTTC, and PTTC are funded by SAMHSA under the following cooperative agreements. The views expressed in this webinar are the views of the speaker and do not reflect the official position of DHHS or SAMHSA. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. We do have a few housekeeping items for you. If you are in need of any technical assistance, please individually message Alyssa Kuala or Rebecca Buller in the chat section, and we would be happy to assist you. If captions or live transcript would be helpful, please locate the caption option on your Zoom toolbar. If you do have any questions for the speaker, please put all questions in the Q&A section of your toolbar, as we are going to be taking frequent stops throughout the presentation to answer your questions. You will be redirected to a very short survey at the end of the presentation. It should only take 2 to 3 minutes, and it would be greatly appreciated if you filled it out. Certificates of attendance will be sent out via email to all who attended the session in full. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn, our YouTube, and our podcast channel. I'm very honored and excited to hand this over to our presenter, Elizabeth Salisbury Afshar. Thank you so much for being here, Elizabeth.
Hi, thanks so much for having me. As was mentioned, my name's Elizabeth. I am a physician. I work at UW-Madison. My clinical practice is fully in addiction medicine, but I also trained in family medicine and in preventive medicine, public health. My career has been always sort of split between clinical medicine. I've predominantly worked in outpatient settings in federally qualified health centers. I did that at work in Baltimore and then in Chicago and now in Madison, Wisconsin. I also work on our inpatient addiction consult service. And then sort of the other half of my work has always been very focused on policy and sort of implementation of programming. I've worked for public health departments in Chicago and in Baltimore, overseeing our strategies as it relates to reducing overdose. And here in Wisconsin, I am the medical director of harm reduction services for our DHS. So worn a lot of hats. I'm really excited to be here with all of you today. And let's see if I can get my slides pulled up here. Give me just 1 second. Okay, can you guys see everything okay?
Yep, everything looks good.
Okay, perfect. So again, I just want to ask if folks have questions throughout. I'm going to stop at a few points throughout the slides just to answer anything. Please put them in the Q&A. And I'm going to have some help from Rebecca to keep an eye on things just to make sure that we're answering questions as we go. So I was asked today to talk about buprenorphine initiation in the age of fentanyl. And the learning objectives are to first be able to describe the evolving non-pharmaceutical opioid supply, so sort of all of the changes in our drug supply. Then to be able to talk about some of the challenges that we're seeing that relate to starting buprenorphine, or sometimes the trade name that people are more familiar with is Suboxone. I just want to pause here and say I use the term buprenorphine throughout, and really I'm talking about any of the buprenorphine products, and just, you know, to not be I won't use trade names. So just know it's not that I'm talking about the mono product alone, but Suboxone, Subutex, Zubsolv, all of those things would be included in this term. By the end, everyone should be able to name 3 potential approaches to starting buprenorphine, and finally to be able to counsel someone on reducing fentanyl-related harms. And this is a slide that I'm guessing folks are already really familiar with, but I think it's always just sort of a good place to start and remind ourselves that we continue to see significant increases in opioid-related overdose deaths. And this top line is just looking at any opioid-involved death. You know, in the earlier years of the overdose epidemic or overdose crisis, really the leading cause was related to prescription pain medications. And you can see here from 99 until about 2010, we were on this slow, steady increase. And then in 2010, things started to level out, particularly as we started to have a lot of efforts to reduce opioid prescribing. Around that same time, we saw significant increases in the number and the rate of heroin-associated overdose deaths. And then really just a couple years after that, we saw this dramatic increase in the number of deaths involving fentanyl. And really, we've continued to see this trend. In the earlier years of fentanyl, really most of the drug supply that had fentanyl in it started in the Northeast and has just continued to make its way west. We've had pretty pervasive fentanyl involvement in the drug supply in the Midwest for a number of years now. I've lived in Madison for almost 3 years, and before that was in Chicago. And I can honestly say, I don't remember the last time I saw a urine toxicology in the clinical environment that had only heroin in it, meaning heroin without fentanyl. At this point, I would say, you know, at least the market that I'm in, opioid drug supply is ubiquitous. Like it's all going to have fentanyl in it. Sometimes we still see a little bit of heroin, but you know, fentanyl seems to be here and here to stay. And so really this third wave has been a wave of synthetics, including fentanyl or the fentanyl derivatives. The things not represented here that I do just want to acknowledge is that we are seeing more and more deaths that involve stimulants, whether that be cocaine or methamphetamine. And often these are sort of polysubstance deaths being, so it would be, you know, methamphetamine plus fentanyl or cocaine plus fentanyl, but we're also seeing increasing rates of stimulant alone overdoses. And then of course, just really within the last year or two, we're now hearing about other substances being cut into the drug supply, things like xylazine that are increasing risk of death, or at least concerned that there's increasing risk of death. And so we continue to see this really evolving quite quickly. And we're often sort of trying to play catch up with understanding why people are presenting with the symptoms that they're having. And do we need to adjust our approaches to medication treatments? This is a map looking at overdose death rates. The dark green color are the states with the highest overdoses. So you can see we here in the Midwest continue to have pretty high rates of overdose. Places like West Virginia have, you know, long-term had the highest rates, but unfortunately we in the Midwest, you know, many of our states fall among that highest tier of overdose death. And so I think it's an important question to ask, like, why are we seeing so much fentanyl in the drug supply? If it's so dangerous, you know, why would suppliers even put it in there? And I think, you know, really there's not a single answer, but it's a variety of factors. So I think at this point, people in public health would not argue that our original focus on trying to reduce access to prescription medications for pain, prescription opioids for pain, really did sort of leave this huge gap. So we started prescribing less, pill mills were being shut down, people had less access, and drug suppliers, people who make drugs, saw this vast market. And these are really market forces at play. So there are lots of people who want opioids, lots of people who had been using opioids, all of a sudden supply is down. And so people came in and said, well, we can fill this gap. We have seen increasing availability through things like the dark web. So people being able to actually order these substances online. We're seeing increasing numbers of labs. So if you think about trying to make heroin, right, you have to grow poppy plants, you then have to process them, and then you have to ship everything over. These are synthetic substances. They're made in often small labs. Because fentanyl is so potent, it requires a much smaller amount. So this is easier, right, to be able to ship into other places and move around both between continents and between countries, as well as within a country. And it's been highly, highly profitable. In 2016, the DEA reported that the wholesale price per kilo of fentanyl was between $2,000 and $4,000. So that's but then the street value is between 5 and 20 million, right? So just massive opportunity for economic profit for the people who are selling substances. And so I think all of these things have contributed to the increasing amount of fentanyl in the illicit opioid supply. This is just showing the various ways that drugs come into the country, and this is already admittedly probably outdated. We are continuing to hear more and more reports about these labs that are popping up in Mexico. So it's not historically, initially, it was really thought to be largely coming out of China. We're seeing more and more labs in other countries now as well. And again, because this is synthetic, it doesn't mean that they necessarily need, the farms and the fields that we did in the past to be able to produce heroin. So I'm sure many folks are already familiar with this, but just at a high level, I think important to review. So fentanyl is about 100 times as potent as heroin, if like by weight, right? So if you were given the exact same amount of fentanyl as compared to heroin, it's significantly stronger. And the analgesic effect, or like that pain relieving, sort of those positive properties, don't actually last as long as the respiratory depression. So sort of the positive effects that someone gets will end before that slower breathing rate ends. And this is one of the things that can make it challenging, because if someone continues to use because they're looking for that positive effect, the relief of pain or whatever it may be, it can have this sort of additive effect on respiratory depression. Another thing that's really important to know about fentanyl is that especially for people who use it frequently and in larger volumes, it does get stored in the fat cells. And so when someone uses fentanyl, it crosses the blood-brain barrier really, really quickly, which means that people get sort of an immediate, again, an immediate positive effect from it, whether that's euphoria or pain relief or whatever it may be. But then it gets distributed into the fat cells and the muscles. And for people, again, who are using really like frequently and using in larger amounts, it stays in those fat cells. And so one of the interesting things about fentanyl is that we'll see for people who use regularly, they will continue to have norfentanyl, which is a breakdown product of fentanyl, in their urine for sometimes weeks. And in one case, this was a study that looked at people in residential treatment. There was one participant who continued to test positive for norfentanyl for a full 26 days. And this might be something that folks are seeing clinically, that someone's coming in, they're saying, no, I'm not using. But if you're getting a confirmatory test, you might see that norfentanyl remains positive for a number of weeks. And we think that's because, again, it's being distributed into the fat cells and it's kind of slowly leaching out, if you will. There's some more information on pharmacokinetics here. I'm not going to go through that in detail, but happy to talk about it if folks have questions. It does go through the liver. It does stick around, at least in terms of being measurable, for a number of hours. And so it has this long half-life and this sort of really slow process of leaving the fat stores. So we've started to see some challenges as it relates to buprenorphine initiation. And again, buprenorphine could include anything, any of the different formulations of the medication. And what we've been hearing for a number of years now is that more people are reporting precipitated withdrawal, but it's not everyone, and we're going to talk about that. And we're also seeing that that people seem to have a much higher tolerance, again, probably because of the potency of fentanyl. And for folks who are using it pretty regularly, we'll see that their tolerance will go up because it is such a strong opioid. I'm going to go through some of the reasons why this happens, as well as talk about some ways we can adjust our prescribing. But it's really helpful for me just to have a sense of the audience. So if we could, I want to just ask a poll to find out how many people in our audience today are buprenorphine prescribers. Okay, great. So that's really helpful. So it looks like 13 or 14% of the audience, oh, and I think I just messed something up, are buprenorphine prescribers. So I am going to say, for the context for today's conversation, I'm not going to go super deep into all of the nitty-gritty details of prescribing, since it seems like we mostly have a non-prescribing audience, but I am happy to answer questions during the Q&A. And I'm just going to try to kind of stay at a high level as it relates to the different approaches and why they work or why they might be challenging. So the concept of precipitated withdrawal is kind of like this, and this is a graphic that comes from an article in the Canadian Journal of Addiction. So I hope that the images are helpful. But essentially here on the left, this is opioid receptors when all of the receptors in the brain are filled with a full agonist opioid. So this could be fentanyl, this could be methadone, this could be heroin, right? Like any opioid that fully turns on the opioid receptor. When all the receptors are bound, we see that the opioid activity, or the mu opioid receptor activity, is sort of at a max. So it's fully turned on. Buprenorphine is what we call a partial agonist, which means that when the buprenorphine is attached to the receptor, it turns the receptor on, but not fully, right? And so when you have a full effect at the mu opioid receptors, this is when people experience those positive effects, whether that be pain relief, emotional pain relief, euphoria, whatever it is, it's sort of fully turned on. So if then someone was to take a bunch of buprenorphine while all these receptors were full with we'll just use fentanyl for this example. And they took a bunch of buprenorphine and it quickly pushes all of the fentanyl out of the way and goes and attaches. It turns that opioid receptor activity from a max down to sort of a mid-range, because it's turning the receptor on, but it's not turning it on to 100%. So immediately when that happens, you start to see that the amount of receptor activity is going down, and it's that going down in receptor activity that actually causes people to have some withdrawal. So when they first take the medicine, they're kind of, the amount of receptor activity is going down. 20 to 30 minutes later, they hit kind of this halfway turned on point, if you will. And this is when people will have some of those really common withdrawal symptoms. They might start sweating, muscle aches, nausea, vomiting, diarrhea, runny nose, right? Pupils get bigger. So all of those signs and symptoms that many of us have seen, we'll see if we give a high dose of buprenorphine while somebody, fairly recently after they've used other opioids. Now, the way that we've historically dealt with this is we said, okay, well, you need to wait for a certain number of hours since your last use, and you're gonna try to take a sort of a small to medium sized dose, and we're gonna sort of slowly build that up over the course of a day or two. And as long as you wait long enough, right? If you wait long enough, you shouldn't have those receptors all filled up. So there'll be some open. And so the buprenorphine isn't sort of pushing anything off the receptor. So that was our traditional approach to starting buprenorphine. But what we've been hearing, again, initially just anecdotally, is that in markets that have seen a lot of fentanyl, we're seeing that some people seem to be having this precipitated withdrawal even when they're waiting, even when they're coming in some withdrawal, that the buprenorphine is causing this precipitation that we haven't fully understood. And so really for the last number of years, I would say at least 5 or 6 years, there's been this ongoing conversation about, do we need to adapt our approach? It was probably 5 or 6 years ago, I was working on a project, maybe it was just 4 years ago, in Delaware, and there was concern. And so again, the Northeast has had significant fentanyl in their drug supply for many, many years now. And one of the people I was working with said, look, I don't know if it's even safe to do traditional, like the old way, initiation anymore. I think maybe everybody needs to be doing this inpatient. And I thought, oh my gosh, we can't. I mean, one, it's not paid for service in most places. Two, like our hospitals wouldn't really have capacity. So I was really curious, and I emailed colleagues all up and down the Northeast. And I said, hey guys, what are you seeing? Like, you've had fentanyl in your drug market forever. Like, what are you seeing in terms of precipitated withdrawal? And I got all these responses that were really variable, which I thought was really interesting. But I think the most useful response was from a colleague, Dr. Ruth Potee, who works in Western Massachusetts, and she works in a jail and she works in a detox, and she has all these different clinical environments. And she said, look, Elizabeth, I am in settings where I get to watch people in the whole process of withdrawal. We're monitoring their, we're measuring their clinical opioid withdrawal. And it's super strange because I can tell you we're definitely seeing some precipitated withdrawal. We use the same algorithm for everybody that comes in. And there's this small subset of people who it kind of feels like no matter what we do, like even when we try to wait as long as we can and we try to give them all the support meds, they're still having withdrawal. And I don't know how to explain it. It doesn't seem like it's just one thing. It's not that they've used longer. It's not that they're using more. Like there's not a reason, but there is this small subset of folks. But she was also clear, it seems to be a small subset. It's not everyone. And so I think one of the first questions we have to ask ourselves is, how common is precipitated withdrawal, right? It seems at this point obvious that some people are experiencing it. It seems to be likely due to fentanyl, but how common it is, we don't really know. And I think this is an important question to ask, because if it's 5% of the people, it doesn't, in my mind, necessarily mean we have to like throw everything out and start over with new approaches. But if it's 95% of people, then it probably means we need a totally new approach, right? And so the answer to this question, I don't know. How common precipitated withdrawal is, we aren't sure at this time. I'll go through the few studies who have attempted to answer this, and it's a big range. Anywhere from 1% to almost 30% of people reporting precipitated withdrawal, or 25%. But the key thing is, it's still not the majority of folks. So we know precipitated withdrawal happens. We need to expect that it can happen, especially for people with chronic heavy fentanyl use. But we also shouldn't expect that it's going to happen every time. And so how common it is depends on a few things. So one, how are we defining? Like, how are we actually, like, what are we going to consider precipitated withdrawal? Other factors that seem to play a role, the duration since last use seems to be a really important factor. And we'll talk about this on the next slide. So if I start buprenorphine 5 hours after I use fentanyl, I'm going to be much more likely to have precipitated withdrawal than if I start buprenorphine, 50 hours after my last fentanyl use. The prevalence of fentanyl in local drug supply also probably makes a difference. So again, West Coast and Southwest still have some heroin. So if you're in a place where it's like some fentanyl exposure, some heroin exposure, probably less likely, again, because heroin doesn't get stored in the fat cells the way that fentanyl does. How long somebody's been using fentanyl, so years and years and years and years, probably more risk. Severity of the current withdrawal state. So if somebody comes in with a COWS score of like 16 or 20, already in a lot of withdrawal, the chance that I'm going to precipitate withdrawal with buprenorphine is much less than if they come in with a really mild withdrawal. Again, the idea there being, well, they're already in a lot of withdrawal, so they already have a lot of those receptors in the brain open. So the chance that I'm going to precipitate it is pretty low because the receptors are open. Adding buprenorphine is just going to turn them on partway. And I will acknowledge, I think there's a lot here we still don't know or understand, and I think this will be an area of continued research. So I'm sorry, there's a lot of words on this slide, but this is a study that just came out within the last year. And the authors were trying to answer the question, how common is precipitated withdrawal? Now, they were looking at outpatient treatment. They looked at 49 addiction treatment centers in the United States. So that's great. That's really helpful, right? It's a broad swath of the US. 1,679 people they looked at. And to be included in this study, folks had to identify as being pretty sure that they were using fentanyl. So they didn't require a lab test, but they had to be either certain or pretty sure that they were using fentanyl. And then they were coming in to either start buprenorphine or start methadone. Now, the key thing with this study is that this is based on self-report. So they did their normal thing, they prescribed the meds or dispensed the methadone, and then they let the client themselves determine what they were self-identifying as significant or severe withdrawal. So they weren't measuring it, they weren't using a COWS score, this is what the patient perceived. So of all these 1,679 people, what they saw is that among those who took buprenorphine within 24 hours of their last fentanyl use, almost a quarter reported that they had severe withdrawal. And again, severe was based on the person's own personal experience. So almost a quarter of people, that's a pretty high number. So within that 24 window, so use fentanyl, 24 hours later start bup, about a quarter said they had withdrawal. Now, for people who were able to wait 2 days, so 48 hours since their last fentanyl use, only 8% reported having precipitated withdrawal. So as they waited longer since their last use, we saw less withdrawal. Now, they compared this to methadone initiation, and this is important. They used methadone initiation as the control, not because we think that methadone really precipitates withdrawal, but because we know anytime you're starting a new medicine, it can be really stressful. There's lots of anxiety. So they used this almost like a placebo, but it's not a placebo, right? Because methadone definitely has chemical activity, but they used this as a comparison group because at least our understanding of the pharmacology of methadone is it should not precipitate withdrawal. It's a full agonist. It should be turning on the receptor. And so in that case, 12% of people who took methadone reported that they experienced withdrawal, and 1% who waited 48 hours. So basically, it's just saying rates of withdrawal are much higher when people use buprenorphine as compared to methadone. And regardless of the medicine, the longer people wait, the less likely they are to have withdrawal. And this is just basically the same information, but visualized in graphically. So, 24 hours here, rates of buprenorphine inducing withdrawal is, again, here 24%. And then the longer folks wait, the less the risk for experiencing any withdrawal. And then methadone, overall lower rates of withdrawal, but realistically, we wouldn't usually expect any withdrawal to be precipitated by methadone. So I think it's also possible that some of what we're seeing for the methadone category is more related to just sort of all of the stress and anxiety that comes with starting a new medicine, that also maybe comes with just trying to not use for a little bit before you start, and sort of all that goes into that. So the key point here is the longer someone waits, the less likely they are to have withdrawal. Now, interestingly, so 22% in that study of outpatient patient self-report, when we move over and look at the emergency department literature, we see much lower rates of precipitated withdrawal. Now, there are a few reasons this could be happening. Number one, they're using a much stricter definition of what counts as withdrawal. They're actually visually watching people. They're measuring the clinical opioid withdrawal scale. And then they're typically only calling it precipitated withdrawal if the COWS score actually goes up or goes up by a certain amount. So a slightly stricter definition. And in these ER studies, what they've seen, and there have been 2 separate ones now, they've seen about a 1% rate of precipitated withdrawal. Now, the other key difference in the ER is that folks coming into the ER are often already in withdrawal, either because they got naloxone in the field because they were surviving an overdose, or because, you know, they're in a lot of pain, or they're out of money and they're in withdrawal, and like there are other factors going on. And so these folks are often a bit further along in their withdrawal anyway. So that might be contributing to why we aren't seeing so much precipitated withdrawal. So to try to answer that original question, how common is it? I don't know exactly. I would say it's not the majority of the time. It's probably somewhere between 1% and 22%. But the longer someone can wait from their last fentanyl use to start buprenorphine, the less likely they are to have any precipitated withdrawal.
Elizabeth, we do have a question that pertains to what you're talking about right now. The question is, won't patients who are waiting to start treatment experience withdrawal naturally?
Yeah, that's exactly right. So, and this is the thing that we're always up against, right? So if I tell someone, you know, if you can wait 48 hours between your last fentanyl use and when you take your first buprenorphine dose, you're much less likely to have withdrawal. Well, okay, that sounds nice, right? But what it means is that during that 48 hours, their withdrawal symptoms are going to continue to increase. And so essentially what's happening at the brain level is that as the fentanyl and, you know, or whatever opioid they're using is no longer attached to those receptors in the brain, we're going to have more and more open receptors. And the goal is that then when you put that buprenorphine on, it's not reducing the receptor activity, it's actually increasing it, because now you're going from a receptor that was totally open to having buprenorphine there, so it's turned partially on. And so if folks come in enough withdrawal and we give them buprenorphine, it's like, oh, thank goodness, it's such a relief, I feel so good. If folks come in having just used and we give them buprenorphine, the risk that we're up against is that the buprenorphine is going to reduce the activity and precipitate withdrawal. So that's sort of the difference between the natural withdrawal cycle and precipitating withdrawal, if that makes sense.
Sure. There's a couple more. Do you want to take them now, or would you like to continue?
Sure. Yeah, that's fine. We can go ahead.
Sure. It says, is it possible a less potent drug like methadone leads to withdrawal because fentanyl is so potent, like using less alcohol?
Yeah, it's a good question. I think it's something that needs further study. One of the things that matters a lot in this space is what we call the mu receptor binding affinity. So it's basically how tight does a substance go and attach to that receptor. Buprenorphine attaches really, really tightly. So it will kick other things out of the way. So if you imagine like 100 little receptors sitting there, like waiting, buprenorphine will kick other stuff out of the way. Methadone's binding affinity isn't so high. So it usually, at least based on the studies that we have and based on the numbers, and they're usually based on like a combination of rat models and like, so none of it's perfect. And we should never assume that any single like chart is exactly representative of the patient in front of us. But generally speaking, methadone doesn't have such a high binding affinity, and we wouldn't expect it to kick fentanyl out of its place, which is one of the reasons why we typically don't see as much precipitated withdrawal. Now, again, are there people who are sort of outliers, if you will, who have some type of different receptor? Like it's possible. And so I'm always cautious, never say never, right? But at least based on our understanding of the pharmacology of it and the binding affinity, it's less likely that methadone would be kicking fentanyl out of the receptor.
Here's one last one. What does, if any, effect on the wait time to start Suboxone if the patient has been given a dose of Narcan?
Yeah, that's a great question, and something we'll talk about in just a minute when we get to the ER studies. So I think there's been increasing interest and definitely increasing practice, not as much in the published literature, but a little bit, about if we've done something to throw someone into full-blown withdrawal, like give them a bunch of naloxone to resuscitate an overdose, that can be a great time, right? Because essentially the naloxone's already kicked all the opioids out of the receptors. And that can be a great time to just say, okay, well, you're already in withdrawal. Let's just go ahead and do it. Let's just go ahead and start buprenorphine right now. There are actually some places where EMS, like the paramedics, will be able to start buprenorphine in the field for people who have just survived an overdose. And because that buprenorphine has that tight binding affinity, like once it's on that receptor, it really stays there for a good like 24-ish hours. It's really protective against another overdose as long as we give a high enough dose. So it'll sit there. And even if more fentanyl comes in, it'll kind of like block the receptor for the day or so that it's there, as long as the dose is high enough. Yeah, so that's a great question.
All right, let's continue.
Yeah, thanks. So I also just wanted to acknowledge, so my initial question was, well, how common is precipitated withdrawal and what does it mean for practice? So people know it's happening. How much is happening, we don't really know. But the challenge is that our patients know that it's happening, or at least they know someone probably to whom it's happened to, and they're really afraid. They're afraid of taking a medicine that's going to make them feel worse when they already feel not good, And so this was a great paper by Kim Soo, Sean Cohen, Jess Tilley, and Avi Yosheved, and I apologize if I mispronounced that last name. Really saying that in some of the folks that are the authors here are themselves people with lived experience, and basically saying like, look, people are really afraid to use buprenorphine right now. They're afraid of withdrawal, and clinicians need to listen to that. And we need new approaches, and we need better ways to support people. Just telling someone, oh, well, just don't use for 2 days, right? And like be in agony is sometimes just not feasible for people, with all the things they have going on in their lives. And so this is a quote from the paper that says, whether attempting novel or conventional initiations with buprenorphine, patient autonomy and patient input are critical to successful initiations and ongoing collaboration. And I think, the thing that so often clinicians want is like, Elizabeth, just give me the algorithm that I'm going to use every time for every patient and that, is most likely to work. And I think what we're seeing right now is that different people respond really differently. Some of it's probably related to the psychological stress and trauma and concerns people have about it. Some of it's probably related to the pharmacology of these meds. But regardless, like we need to work with our patients on things that feel reasonable to them and give them all the supports that we have. And admittedly, I think we're still learning and hopefully we'll have more in the future. But to make this as successful as possible, right? The only successful medication is one that someone can take and someone's willing to take. And if we don't work with them on that, my concern is we're going to see more and more people who are just not willing to try because they've had a bad experience or they've met someone who's had a bad experience. So what are the ways that we can support patients around buprenorphine initiation? So one is to provide comfort meds early during withdrawal, and we'll talk about what those are. So really letting people know like that you are going to have some tools that you can use. We know withdrawal sucks, right? Like it's not pleasurable. And we're going to ask you to wait as long as you can to start buprenorphine in many cases. And if you're going to do that, we want you to have some tools to be able to get through it. We want to be able to offer adapted buprenorphine initiation schedules, and I'll talk about sort of 3 different approaches. And then finally, if something happens where taking buprenorphine precipitates withdrawal, right, like actually makes withdrawal worse, we want to make sure that we're treating those symptoms as well. So comfort medicines, first medicines like lofexidine or clonidine can be really helpful with a variety of symptoms related to withdrawal, but particularly some of the anxiety and agitation, elevated heart rate, things that people feel when they're going through withdrawal. Ondansetron can help with nausea, loperamide with diarrhea, and then other meds like dicyclomine, acetaminophen, NSAIDs can help with some of like the overall muscle aches. And these are things that are, by and large, really safe medicines as long as people are taking them at the prescribed doses and things that we can and should be offering. I tend to work with folks who are very low income and many of whom have problems with health literacy. And so I will just say, I usually offer them to people and just kind of say, like, what are your worst symptoms when you're having withdrawal? For a lot of people, it's that anxiety, agitation. I also live in Wisconsin, where our Badger Care or Medicaid plan has a copay for each of these meds. So most of my patients cannot afford to get all of them filled. So it's really about, okay, what are the most bothersome symptoms? Have you tried any of these things before? Which one of them would be helpful? And then we sort of make a plan together around what they think might be useful for them. Often we will actually encourage people to start these medicines before they're even experiencing withdrawal symptoms, right? Like 6 hours before, 8 hours before, just because we're going to expect that they're going to be having some withdrawal through the natural course prior to starting the medication. In terms of buprenorphine initiation, so I'll go through these columns pretty quickly, and again, happy to answer questions. So our traditional approach to starting buprenorphine was usually, okay, wait at least a day. We want you to have a clinical opioid withdrawal score of 8 to 12. So this is sort of moderate withdrawal. We want you like entering moderate withdrawal, so pretty uncomfortable. And then we used to recommend starting with 4 milligrams, and then you can repeat, several times on day 1 and go up to 16 milligrams on the first day, and then sort of reassess and sometimes go up to 24, later that week. Historically, this was the way that we did it for the first 10, 15, years of buprenorphine initiation. We've looked at it in all different types of settings. Then fentanyl came on the scene, and we've started seeing these newer and alternative approaches. So one is low dose initiation. So this is a slightly different approach where we said, okay, well, if the 4 milligrams is precipitating withdrawal, or let's say even people are just like, look, I cannot wait 2 days to start buprenorphine. Like, I can't just be sitting there for 2 days going through withdrawal. I'm not going to make it. It's too intolerable to me. Another way you can do this is sometimes what's called cross tapering or low dose, where the idea is rather than giving a dose of buprenorphine that's big enough to start kicking all those opioids out of the receptors, we're going to give little baby doses. And we're going to sort of really slowly start to increase it so that, yeah, it is sort of kicking out a little bit of the full agonist opioid out of the receptor, but not enough to cause a big precipitated withdrawal state. Now, the tricky thing with low dose initiation, and the reason that it's called cross tapering, is that as you give these baby doses, people do continue to use another full opioid agonist. So in the inpatient setting, this often means I'm prescribing a pain medicine while giving these little baby doses of buprenorphine over the course of 3 to 8 days. And that really slowly the buprenorphine will sort of reach the point where it has enough receptors that it has full effect, but it never precipitates anything. So that is one approach. It's harder, I will say, my experience has been that it's harder in the outpatient setting, because what we're telling people is, I'm going to give you this medicine. I want you to take little baby doses. And the whole time I want you to keep using fentanyl or whatever, your opioid of use is. So you're going to, and people are like, wait, what? Like, you're starting me on treatment and you want me to keep using? Like, this is very confusing. And so it often takes a little bit of time to kind of walk people through it. And I'll give a dosing example on the next couple slides. The other option is this high dose initiation. And I will say I just went to a conference last week. Prior to attending that conference, really the only setting where I've heard this really high dose initiation happening was in the ER. It was mostly, post overdose cases. So somebody has an overdose, they get naloxone, they're in full blown withdrawal. And it's like, oh, wow, this is our time. Like, let's just start a lot of bupe right now because their receptors are empty, right? They're already uncomfortable. If we just give bupe now, it's going to bring the empty receptor up to halfway and they're going to feel better. I will say, at this conference, and I haven't seen anything in the published literature, but I met multiple colleagues, especially from out east, who said, oh yeah, I'm doing this now. And the reason I'm doing it is because people struggled so much with this idea of like slowly increasing buprenorphine over the course of many, many days. It's sort of a complicated dosing strategy, and patients were just really struggling. So at some point I just said, okay, let's just do it. Let's just do high dose. I tell people to wait as long as they can, at least 24 hours. And then we just start with a higher dose. Sometimes they have a little bit of withdrawal, but we just keep giving more buprenorphine up to 32 milligrams on day 1. And then they're done with it in a day. And yeah, that one day can be kind of rough, but they're done with it in a day. And a lot of patients prefer this. So while I will admit having these sort of 3 different approaches is more confusing as a clinician, I will say in working with patients, I meet some patients who are like, oh yeah, this way, this 4 milligram, like I've been doing this on and off for years. I can do that. And I'm like, okay, great. And then I meet some patients who are like, oh no, I've precipitated withdrawal before. You've like, there is no way I'm going to do it that way. Like, and they're more open to this concept of these little doses over the course of a number of days. And then I've met people who are like, look, doc, I just need to get it over with. Like I can handle it for like a few hours, but like, I need to be started on this medicine. I want to be done with using, right? And so I do think that this is really about collaborating with our patients and coming up with an approach that makes sense for them. Let me just do a quick time check. So this low dose initiation, again, this is just a visual representation. So the idea is you wait until there's a little bit, you know, like they've waited a little bit, and then you just really slowly start putting buprenorphine in. So on day 1, you know, low dose, often 0.5 milligram or 1 milligram. Day 2, you're like just slowly inching your way up, so that you're never having this big drop from full receptor activity to half receptor activity. You can see over on these little net effect wheels, I guess, that it's just happening really, really slowly so people don't experience this big drop. This approach often takes about 3 to 8 days. So it does take some time. And I just, as references, there's a link down here. This is from the California Bridge program. This is totally free resources. They give 2 examples of a 3-day cross taper start and a 7-day cross taper start. So again, this is really where we can work with our patients. And the goal is just over the course of however many days, you're slowly increasing the dose so that it doesn't cause that big drop in terms of precipitating withdrawal. The other approach that I mentioned is this high dose approach, or sometimes called rapid start. I will also just say here, sometimes people refer to this as quote microdosing and macrodosing. There's been a push within the addiction medicine community not to use those terms because especially microdosing has a lot of contextual implications as it relates to psychedelics. And so we're just trying to be very specific, low dose or high dose or traditional dose. So in this high dose initiation process, you want to make sure people are in adequate withdrawal. The ER studies have recommended that they have a clinical opioid withdrawal scale of at least 8. So that's still a pretty mild withdrawal. And then you give your initial dose. Well, they said 4 to 8, but in most of the folks I'm talking with, they're usually talking about 8 to 16 milligrams for the first dose. And then on day 1, you go up to 32 milligrams. And again, the idea here is that first dose may precipitate a little bit, but really the way you deal with it is just keep giving more buprenorphine as long as they're up to 32 milligrams. And by the time you get to 32, at least anecdotally, what I'm hearing from colleagues is that people are feeling pretty comfortable. There are examples of post-overdose reversal in the ED where the COWS score is lower, but somebody, again, has just survived an overdose and they're giving 16 milligrams in a single or divided doses over a couple hours. So again, the idea here is we're just going to rush the system with buprenorphine. People may experience a little bit of withdrawal, and as they experience withdrawal, we're just going to give more until they're comfortable. And that usually is somewhere between 24 and 32 hours, again, at least based on anecdotal reports. This is literally just cut and pasted out of this JAMA Network Open study, which was an ER study describing what they do. The key thing here that I want to acknowledge is that I would never recommend a high dose initiation if someone isn't already in some withdrawal. So if somebody came in and said, oh yeah, I just used fentanyl 20 minutes ago, if I give them a huge dose of buprenorphine, it will precipitate withdrawal. So they, in the ER studies, I just want to again acknowledge they do have a COWS score of greater than or equal to 8. So people are already in some withdrawal. And this is just a review of the findings. So, you know, again, 1% of people in this ER study reported withdrawal, and they were able to treat that withdrawal with additional buprenorphine. And so yeah.
Oh, sorry, we had a quick clarification. Are you seeing breakthrough cravings with either of these initiation methods?
So that's an interesting question. I mean, during initiation, and I would love to hear others' experiences. So if others have thoughts on this, you can either put it in the chat or put it in the Q&A. My experience working with patients is that initiation is stressful no matter what. And people, no matter how committed they may feel, like most people come in with just a ton of anxiety around the process. Cravings is a largely like cravings in my mind is sort of different, and then it's a largely psychological, like all of the brain cycles that we've built over time because human beings love, consistent behaviors, and drug use is for many people a consistent behavior. So I think about cravings as more of a psychological context. I would imagine that most people, I don't think about initiation as a means to manage cravings. I think about initiation as a means to get someone on a medicine in the safest way possible. But I find that for most folks, initiation is pretty stressful. So I'm not necessarily asking about cravings like in the moment, because people feel really nervous and often feel kind of awful, right? Like if you come in with an elevated COWS score, yes, you're having cravings, but you're here because you want treatment. So I don't have a perfect answer to that. What I would, where I really start looking at cravings is when talking about dose stabilization. So a few days out, a week out, a few weeks out, right? Like that's where I think cravings really come into play. In my experience, most people are having some level of cravings, thoughts of use, lots of anxiety during the initiation phase, because it's kind of the unknown and it's a big change. It's a big change in behavior, or at least a goal to make big behavior changes, and that's stressful.
Thank you.
Yeah. So then with any of these initiation processes, less so with low dose initiation, I've never really seen precipitated withdrawal with low dose initiation, but with traditional or high dose, I mean, it is possible that we precipitate withdrawal. And so the general approach I would say at this point is just to give more buprenorphine. So if you give a dose, or if someone takes a dose and it precipitates their withdrawal, at that point, you kind of have to make a decision. Do you keep going and just add more, or do you pull back and say, let's wait a day? When someone precipitates withdrawal, they are uncomfortable. And so the more you can do in the moment to make them comfortable, the better. And again, most folks, at least anecdotally, would say just give more buprenorphine, because our goal at that point is like, let's just push through. Yeah, the next few hours might be really pretty terrible, but then you'll be done, right? Rather than like the agony of being like, okay, wait it out, and here's some support meds, and come back tomorrow and let's try again. Like that's really, really hard. So most folks, myself included, would say, let's just push through and let's just give more if the patient is willing to try it. I mentioned the alternative is waiting for a day and trying again. The problem is if we've precipitated withdrawal, for most folks, their immediate reaction is going to be to want to use again. And then they need to wait another 24 plus hours after that, right? And so people can kind of get into this cycle of just having a really hard time starting. And then finally, using those support meds. And I will just say that there are different folks trying some different things. None of it's FDA approved. None of it's sort of in clinical guidelines yet, but we have heard of folks who are using benzodiazepines, which have some of their own challenges. I just went to a session at the American Society of Addiction Medicine where folks are using ketamine as part of buprenorphine initiation. There are some other non-traditional pharmacotherapies being tried. I would say none of these are quite like mainstream yet. None of them are FDA approved. So I do think there will be more research in this space as well in coming years. So we do have a case here. I just want to pause first to see if we have any other questions.
No, not at this time. Just a couple of comments that people have been sharing, but no real questions right now. And like I said, if you do have questions, please feel free to put those in the Q&A section at the bottom of your screen, and we'll get those to Elizabeth. We have a few minutes left. Great.
So this is a real world case with some minor adjustments just to protect patient confidentiality. So, and the spoiler alert is that this case didn't go particularly well, but it is a real case, and we can talk a little bit about it at the end of what I might have tried differently, sort of, given experiences since then. But this was probably a year and a half ago. Mr. M is a 51-year-old man who came to clinic wanting to start buprenorphine for the treatment of his opioid use disorder. He has a 30-year history of heroin use. He used via injection in his younger years, and in recent years is using only via insufflation or snorting drugs. His only prolonged period of abstinence has been associated with being incarcerated, and he had a single residential stay about 9 years ago. He has a remote history of methadone treatment. At that time, he was on 90 milligrams daily, and his only past buprenorphine use has been from friends giving him medicine when he was having active withdrawal. And at those times, he did feel that it made his symptoms worse, right? So he's had kind of a rocky time with buprenorphine in the past, but when he's tried it, it's just been kind of like him already being sick, friends giving him something, him trying it, and like not super clear how much it helped. He comes in and he's really worried about having withdrawal again. So he's never received a prescription for buprenorphine, never received it in a controlled setting. But he's just really nervous that he didn't have the most positive experiences with it when he tried it from friends. So we talk about all three options, all three of the medication options. He doesn't want methadone. He doesn't want extended release naltrexone. He's interested in trying buprenorphine. He works, he has a labor job, and he's paid under the table, which also means it's hard for him to make appointments. He's also living out of his car because he's experiencing homelessness right now. And so he's also just really worried, like, I can't be having diarrhea all over, like I don't have easy access to a bathroom. So there were lots of really valid and like pragmatic reasons that he was super concerned about withdrawal. So we went through different options, and he said he was interested in trying low dose initiation because his goal was to have zero withdrawal at all. When he had precipitated withdrawal in the past, it was very unpleasant. And this was a quote, "I want to get sober. I want to enjoy the days I have left. I'm really tired of this." We talked about the option for residential treatment, but there was all of this complexity that he was on parole and his PO didn't know he had been using. And there was like, it was very complicated. He didn't have funding for room and board. So it just wasn't an option at that time. So my question for the group, and folks can maybe put this in the chat, is how would you approach his initiation? He wants to avoid any withdrawal at all. Looking but not seeing anything yet, and only because we're so close on time, I'm going to go ahead and move forward, and I'll tell you what we did. So I actually made this handout. He had a lot of challenges with literacy as well, and so I made this handout because my hope was that he could follow it without being able to read the instructions on the bottle, because the other challenge with low dose initiation is it's a lot, like there's a lot going on. So he started with the recommendation was that he start with 1 milligram in the morning on day 1, on day 2, 1 milligram in the morning, 1 milligram in the evening, day 3, 2 milligrams in the morning, 2 milligrams in the evening, and so on. So this shows the total dose over the course of the day. Now, the expectation was he would continue to use. He'd continue to use fentanyl on day 1, 2, 3, 4, 5. And by day 6, he would be up to 12 milligrams. And usually at 12 milligrams of buprenorphine is about when people are able to stop using other opioids, because enough receptors are bound. It provides a pretty good blockade from overdose risk. And so the first 5 days he'd continue to use, which he'd been doing for a long time and still working and sort of managing his life. And then on day 6, he would try to stop. And by day 7, he'd be up to potentially 16 milligrams and we'd see him again. I'm only in clinic 1 half day a week. So this was sort of the plan for his week. So we went through everything. We got him all the films. We made the decision to only give 2 milligram films because, again, of some of the literacy issues, and just thought it would be simpler for him to have the 2 milligrams. And no matter what day it is, he's taking, all the films are the same. And so I already gave the spoiler alert that like this was really, really hard. And I think it wasn't just hard because of the medication. It was hard because of a lot of his life circumstances, living in a car, right? Trying to continue working, really being reliant on that income. And so he would sort of come in and out of care. He'd miss a few weeks and then he'd come back. He would intermittently have buprenorphine in his system. He wasn't saying that it was precipitating withdrawal. He just had a hard time sort of getting the dose high enough to allow him to stop taking other opioids. So buprenorphine would be there sometimes, would not be there sometimes, but then he'd always have other opioids, namely fentanyl, in his urine. And I think too, this was where some of the health literacy and just literacy issues really came into play, because sort of the story and the film count, like nothing ever exactly added up or made sense. And I legitimately don't think he was trying to be dishonest. I think he just had a lot of chaos in his life, and sometimes it was confusing exactly when he used or what was going on or when the last bup dose was or how much it was. And so again, we continue to work with him on residential as an option. Probation really complicated this, or I think it was actually parole. And eventually over time, he was lost to care. He didn't have a phone consistently, so we didn't have good ways to reach him. So this was like not the best outcome. And I fully acknowledge that. And so I think, in the time since then, things that we've come to realize is that working with people who are continuing to use while simultaneously starting medication is really hard. It's ideal if we can offer really frequent visits, whether those be by phone or in person, sometimes like literally even daily, when people are doing this low dose initiation, because it gets confusing. Like, how many are you supposed to be taking, and how are you adjusting, and what do you do if you have some side effect? So a lot of clinics that are doing this are literally doing daily phone check-ins. But again, if your patient doesn't have a phone, that's often not feasible. We are seeing some folks really can manage a schedule like this without problem, but the dosing instructions are not easy to follow for a lot of folks. And so having a handout, or again, doing those daily phone check-ins, can be really helpful. And I think, my biggest takeaway is we still see plenty of patients doing just fine with a traditional initiation. And personally, I'm sort of reserving these low dose initiations for unique circumstances. People who are like, oh no, 100% of the time, I always have precipitated withdrawal, I'm not doing it sort of the normal way. Or people who are like, I cannot tolerate waiting 24 or 48 hours. The benefit of this initiation schedule is you don't have to be in any withdrawal when you start. So for people who are like, nope, I can't do it, this could be an option. And then people who are pretty confident in their own ability to manage their meds, right? Like they can keep track of them. They have a way to cut the films. They, have a phone to do check-ins or come in more frequently to do check-ins, are things that I would really be sort of looking for. Or maybe if you're definitely in an inpatient setting, we do it a lot. That would be another alternative. When I would avoid doing this, again, sometimes we work with patients who are like, I'm here to stop using drugs. Like, I don't want to use anymore. Like today, like yesterday or today was my last day. Like I threw everything out. I, got rid of all the numbers. Like I'm done. I don't want to keep using, because again, to use low dose initiation, people have to continue to use an agonist, an opioid agonist for the first few days. Otherwise they'll be in pretty severe withdrawal. If somebody comes in and they're already in a lot of withdrawal, there's no point. You don't need to do low dose. You're already in withdrawal. We can just move ahead, right? Like the benefit of low dose is that you don't have to. For folks who really want a rapid start, again, they just want to be done. And I think I've mentioned these other two. So again, the 7-dose initiation is something that's published a lot in the literature. And I think a lot of us are seeing like, that's just a long time to drag it out. A 3-day cross taper could be another option. And again, I include the California Bridge resource here if you want to look it up. And then finally, this like high dose initiation or rapid start is yet another alternative. And so I've talked about this at length, but I think the key point here being, there was a time when we were like, here's the way, here's the algorithm, and everybody gets the same. I think we are no longer in that time period. And really at this point, it's about patient communication, collaboration. What are the circumstances of your life? What are your thoughts about continuing to need to use for the first few days? Are you interested in a really rapid start? Can you wait 24 to 48 hours before you start your medication? Like all of these factors play a role in the plan that we take with our patients. I do just want to acknowledge that there's been a lot of concern about whether or not buprenorphine is as effective for people with fentanyl use disorder as compared to heroin use disorder. And I mean, what we are seeing is that, yes, we still see overall good outcomes. I think we still have a lot of room for improvement, but really getting people to an optimal dose is super important. And so making sure that we're sort of increasing dose appropriately. We know that people on higher doses of medication are more likely to be retained in treatment and less likely to use other substances. In the literature, usually that top dose is 24 milligrams. And we are almost at time. So I am just going to say last things. It is really the Wild West of the drug markets right now. Everybody we're working with is likely, if they use opiates or even if they don't intentionally use opioids, they're likely being exposed to fentanyl. We want to make sure our patients know about and have access to naloxone. If they, are interested in using fentanyl test strips to test their substances, particularly stimulants where they might not be expecting exposure, these are really important harm reduction tools. And so I will stop there.
Thank you so much, Elizabeth, and thank you all for your wonderful questions. And I'm so sorry we did not get to all of your questions. We will take notes of it, and we'll see if Elizabeth could potentially answer some of them for you all. before you guys head out, I did put a couple reminders in the chat for you all. If you could please take the 2 to 3 minutes to fill out that post-event survey, that would be greatly, greatly appreciated. This does continue to allow us to provide you free trainings to you all. The recording and the PowerPoint will be made available on our website within a week. So please check back at the Great Lakes ATTC website under products and resources. And the recording should be up by end of this week, beginning of next week. And then as we stated in the chat as well, we will be sending out certificates of attendance to all who attended this session in full, and it will take up to 2 to 3 weeks. So if you guys have any questions, feel free to reach out to us. Thank you again so much, Elizabeth, for being here with us today. You all were so wonderful, and I hope you all have a great rest of your day. So thank you for joining us today.